constantly rescheduling this lecture, but we have to do it. And now remember, students, now next week is one of the most important weeks in the pediatric assessment, right? You will be having several assessments over that week. So on Thursday morning, probably we'll have the IOP, the investigation-oriented practical test. Probably at around 8 o'clock, we should be able to start, and that will be over by 9 o'clock. We have booked the main hall, right? And remember, now out of the 20 marks that you get for the continuous assessments, you are going to get 8 from the IOP. So make sure that you spend as much time as possible on preparing for the IOP, right? That's number one. Then on the Friday, you will have 4 vivas. In the morning, you will have the communication viva and the social viva. So the social viva is based on your home visit, and the communication viva is, based on 2 clinical scenarios that are given at that time. Make sure you prepare for those assessments as well. And in the afternoon on Friday, you will have the acute viva and the portfolio viva. So this lecture, this brief lecture, is going to hopefully help the acute pediatric viva. It's probably, out of all the assessments, that's probably the easiest one, because if you go through this lecture note and if you kind of, remember all the medications, remember all the steps, and maybe from tomorrow, when you go to the ward on Monday, go to the emergency trolley and have a look at the different types of medications that we mentioned here, you can easily get 70 or more, right? So that is why I say that this is probably the easiest examination out of the lot, right? So, of course, emergency management is important once you start your work as a pediatric doctor, but the whole purpose of this lecture is to prepare you for the emergency viva or the acute pediatric viva, right? So because of that, I may have kind of deliberately omitted certain steps, right? So we are going to discuss these 10 case scenarios, right? These are the commoner scenarios that you will get in the acute pediatric assessment. Of course, there might be certain alterations. Sometimes we might combine 2 emergency situations together. But so if you know these 10 emergencies, you can do the acute viva very well, right? So before we move on to the individual emergencies, there are some basic things that you need to do. Now, as you may have already heard this ABCDE approach, right? So A is airway, where you need to maintain the airway. Sometimes you will have to do certain procedures to open up the airway, such as chin lift, jaw thrust, and sometimes you might have to use certain airway adjuncts, such as oral airways or laryngeal mask airways to keep the airway patent. And airway maintaining will include a frequent suction of secretions. And if everything fails, then of course you need to intubate, right? Then of course you think of breathing once you secure the airway. So you do what we call look, listen, feel. Look is looking for chest movements. Listen is listening for breath sounds, and feel is you feel breath coming out from from the patient's mouth, and you ensure that the patient is breathing. This will also include in the hospital setup auscultating, right? And in this step, you give high flow oxygen either via face mask or nasal cannula. And if the patient is not breathing, you need to start AMBU ventilation, right? Or if facilities are available, you need to connect to a mechanical ventilator. C is circulation. Circulation usually includes insertion of 2 wide bore IV cannulas. So this wide bore depends on the age, right? So once you go to the ward on Monday, have a look at all the different sizes of cannula. So each one is color coded. So at least you will need to remember the gauge of commonly used cannula, such as yellow cannula, purple cannula, and the blue cannula, right? So we'll try to insert the biggest cannula that we can get hold of. Of course, sometimes during emergencies, you might not be able to get the cannula in, right? So in those scenarios, you will have to put introsis lines. So make sure, at least if you haven't seen personally, so those who have gone to casualty unit, PCU, you may have seen the introsis gun as well as introsis needles. But if you haven't seen, at least Google and try to see a photograph, because sometimes we give it at the IOP, right? So when you insert the cannula, or when you insert an intraosseous line, generally you take certain blood tests, including blood gas, blood culture, electrolytes, full blood count, and you take blood for grouping and eating, right? And maintaining of circulation also depends on measuring urine output. So this step sometimes will include catheterization as well. So this is how you maintain the airway. So generally, small lymphs who are less than 1 year, we kind of keep the face parallel to the ceiling, right? So that the neck is slightly extended to open up the airway, whereas older children, we call it the sniffing position, where we kind of hyperextend it to keep the airway patent. Now, once you have secured airway breathing and established circulation, then you look at disability. In the first round, you do what is known as Avpu. That is, basically you are looking for the neurology. A is the patient is alert. V is patient response to verbal commands. P is a patient response to pain. U is unresponsive. And then you, of course, expose the patient and look for certain rashes, fever, fractures, if you are dealing with trauma, like that. And while you are doing everything A, P, C, D, there's something called D, E, F, G, that is, don't ever forget glucose, because hypoglycemia can occur in any emergency, and actually, if it is there, it can aggravate the situation. So pay attention to hypoglycemia. Right, now we move on to the individual components. Now, some important thing to say, if you have any query, you can always interrupt me and ask any question. Or else you can type it in the chat box. You will find that there's a chat box in Zoom, so you can type it there. Maybe we can go through all the questions once the lecture is over, right? Or else you can ask any question when you meet me on Monday or Tuesday, right? Or of course, you can ask any of our registrars. So this is the anaphylaxis flow chart. You can leisurely go through it, but I will just mention the most important steps that will be important for your exam purpose, right? So now we talked about airway breathing circulation, that approach when we're dealing with emergency, but this is one exception where we start off with giving adrenaline before we move on to the airway, right? Because when there is anaphylaxis, you need to act urgently, right? Every minute that you delay will make it more and more difficult for the patient to recover. So that is why if you are suspecting anaphylaxis, you just give IM adrenaline, right? The dose you will have to unfortunately remember. There are two ways where how we calculate the dose. One is based on the age. I will mention it. I will state that in the next slide, and based on the weight, one based on the age, right? The two ways. You will find that most of the emergency rooms, including our emergency room and PCU, they will have the emergency drug doses already mentioned in the notice board, so that you don't waste time even calculating, right? So you also need to know what type of adrenaline to use, right? So adrenaline vial, usually it is 1 in 1,000. So we use 1 in 1,000. When we give IM, you might remember from your medicine experience that if you are giving IV, generally we need to dilute it to 1 in 10. It's the same with the neonatal resuscitation as well. So you make it 1 in 10,000. But when you are giving IV, it is just you use the vial as it is without diluting. So 1 in 1,000. The dose is 0.01 ml per kg. And this is something that you can repeat every 5 minutes, right? So you first start off with giving IM adrenaline, and the other thing is, where exactly do you give the IM injections? As you know, IM injections are given 90 degrees to the surface, right? And generally the needle that you use is blue needle, that is 23 gauge needle. And the best site would be anterolateral thigh, right? Because it has a big muscle mass, and the adrenaline gets absorbed very quickly. So once you give the injection, then you move on to the airway breathing circulation. Of course, while you are doing that, every 5 minutes, if the patient is not responding, you can give IM adrenaline, right? So, then when you move on to the airway, you might notice certain things like stridor, because of and you might also get angioedema. And if that is there, you nebulize with adrenaline. So generally, as I mentioned, each vial of adrenaline has 1 ml. So you need to give 5 ml of 1 in 1,000. So you break 5 vials. put all those the contents into the nebulizing chamber, and you nebulize with oxygen, right? And this step also includes checking oxygen saturation. So once you start nebulizing, then you move to the breathing. Sometimes there might be respiratory distress due to bronchospasm. If that is there, once that adrenaline nebulization is over, you start nebulizing with salbutamol. And of course, if it is very severe, you might even have to start IV salbutamol. So once you sort out the breathing, then you move on to the circulation. So this step, as we discussed in the initial slide, we will need to include 2 LifeBuoy IV cannula. You will need to give IV 0.9% saline, 20 ml per kg as fast as possible to restore the circulation. And then we give certain other medications also. Although they may not be very helpful in the acute scenario because it takes some time for them to act, but we still start them anyway so that we can at least prevent the rebound reaction. So we give IV hydrocortisone, IV chlorpheniramine, and of course every anaphylaxis child should be monitored at least for 12 to 24 hours because there is a rebound phenomenon. As you know, anaphylaxis occurs when the allergen enters the body, the mast cells release the preformed histamines. So once that is released, the mast cells will start producing chemicals again, such as leukotrienes, those sort of things. So that if you don't monitor them, sometimes what will happen is once the acute situation is over, the patient will respond to adrenaline, hydrocortisone, and the other medications, and he'll be quite well. But 6-7 hours later, because the mast cells are producing more and more chemicals, they will have same symptoms again. So that is why we need to monitor them, right? And of course, if this is due to a medication, right, and you need to clearly give them a card or some sort of a large document where clearly it mentions that this patient is allergic to these medications or something else, right? So that should be there all the time. In other countries, of course, they will be wearing a bracelet, which I haven't seen be practiced here, right? So let's now talk about the doses. You will have to remember IM adrenaline dose, as I said, the easier way to remember is 0.01 ml per kg, 1 in 1000. But of course, during an emergency, or if you don't know the weight, you can give the dose according to the age. So if the child is less than 1 year, say 6 years, we give 0.15 ml. 6 to 12, you give 0.3, and of course, more than 12, you give 0.5, right? Hydrocortisone dose, you can remember the dose according to the age, or the easy formula to remember is 4 milligram per kg, right? It's given IV. Chlorpheniramine can be given both IV and IM. You don't necessarily have to remember. So as long as you can remember the IM adrenaline dose for anaphylaxis, as well as adrenaline dose for nebulization for the stridor, and if you can remember the IV hydrocortisone dose, the 4 milligram per kg formula, that is more than enough. So this is the adrenaline vial. Make sure once you go to the ward, have a look at the adrenaline vial. Usually it is kind of brown because when adrenaline is exposed to light, it might disintegrate, right? So usually there is 1 milliliter of 1 in 1000. In other countries, they have what is known as Epipen. This is also used during the emergency, as well as this is given to patients so that whenever they have anaphylaxis system, they can inject adrenaline themselves, right? So these are known as Epipen. Were not available in the government sector. Of course, if any patient needs it, we can get it down from the private sector, right? Before we move on to acute CV asthma, do you have any question regarding anaphylaxis? Any areas that are not clear? Anybody? So you can either type in the chat box or you can just directly ask. All right, then shall we move on to acute CV asthma? Okay, so as I started off earlier, the whole purpose of this lecture is to prepare you for the exam. So in the exam, you will almost always get either acute CV asthma or life-threatening asthma. Both are, of course, the management is same, right? So how you differentiate this? And acute CV asthma, they are very breathless, but they may not be able to talk in sentences. In life-threatening asthma, they are so exhausted that they will not be talking and they are tired. And when you listen to the chest, it's actually silent chest. right? But the management is going to be more or less same. So how do you management here? Of course, we take the ABCD approach. Right, so Airway, we need to see if the child can talk or not. Then of course this step will include checking saturation. So the different guidelines will mention different saturation targets to give oxygen. For example, if you look at GINA guideline, they will say 94. European guidelines, not the UK guidelines, RCPCH guidelines or NICE guidelines will usually mention 92. But I think for our purpose, we will take it as 92. So if the saturation is less than 92 on room air, you have to start high flow oxygen via face mask or nasal cannula, right? So high flow means you need to give like 6 to 8 liters per minute, right? Then of course we come to breathing. So you have to check the respiratory rate. You look for work of breathing such as intercostal recessions, subcostal recessions, use of accessory muscle. Then when you auscultate, there will be bronchi. If the patient doesn't need oxygen, you can actually deliver salbutamol via a spacer and as in metered dose inhalers, right? Generally, if you give 10 puffs of salbutamol, that is equal to 1 gram of salbutamol, so which is almost equal to nebulization, right? So if a child who's having mild to moderate exacerbation, we can try salbutamol puffs as long as they don't need oxygen. But if they need oxygen, that is, if the saturation on room air is less than 92, we cannot use puffs. We need to do oxygen-driven nebulization, because if you just give plain salbutamol as an inhaler or as a nebulization without oxygen, there is a very big chance that it can increase the ventilation perfusion mismatch and the saturation will actually go down paradoxically, right? So because of that, you have to always, especially if the saturation is less than 90, you need to nebulize with oxygen. So we connect the nebulizing chamber to the oxygen tank and maybe increase the oxygen rate to 10 to 15 liters so that it will generate aerosols, right? So first thing that so as I said, at the exam, you will most probably get acute CV exacerbation or life-threatening asthma. So we give back-to-back 3 nebulizations. So we put salbutamol, ipratropium as well as saline and run it back-to-back 3 times. So usually one nebulization takes about 15 to 20 minutes. So what we generally do is while the patient is being nebulized on nebulization with the first one, we prepare another nebulizing chamber so that as soon as the first one is over, we directly connect the second one so that there won't be any interruptions in between. So like that, you give back-to-back nebulization, almost a continuous one for 3 times or roughly about 1 hour. At the same time, if the patient can't take orally, we give oral prednisolone. But if the patient cannot take orally, then you give IV hydrocortisone. So sometimes these children might be dehydrated, so you might need IV cannula as well as IV fluids. If the child can't take oral, then of course we need to give IV hydrocortisone. Same dose as anaphylaxis, 4 mg per kg, right? So which you can repeat every 6 hours. Then these children should be monitored in the room. So very frequently, every 15 minutes, you need to document pulse rate, respiratory rate, saturation, right? If the first round, that is back-to-back nebulizations, do not work, we'll have to go for IV alternatives, right? Of course, if it works, then of course we can space out the nebulization initially, maybe hourly, then 2 hourly, like that you can space out, right? But if they don't respond to the initial back-to-back nebulization, then of course we'll have to give one of these IV agents. So IV almanophyllene is available, IV salbutamol is available, IV magnesium sulfate is available. If you go through these 3 agents scientifically, that is, if you look at the efficacy of these 3 agents, almost they are equal, right, in terms of efficacy. So the difference is the side effects. So you will find different units use different IV preparations based on the availability and the facility to monitor. Now, IV aminophylline, the biggest problem is it has a narrow therapeutic index. I'm sure you will remember from your old pharmacology lectures. So ideally, you should be able to monitor the aminophylline level, but such facilities are not available. So IV aminophylline, usually you give a bolus unless the patient is a patient had been on had been on theophylline. So if the patient has been on theophylline before they presented to the hospital, then of course you do not give the bolus, just give the maintenance, right? So otherwise you give a bolus followed by a continuous infusion, right? But the biggest side effect is, as I said, narrow therapeutic index, you can get arrhythmia. So the patient should be on ECG and the ECG should be monitored. IV salbutamol becoming very popular. Again, salbutamol ideally should be given as a bolus over 30 minutes followed by infusion. But most of the time, most people will avoid the bolus because it can cause a significant tachycardia and worsen the VQ mismatch. Good thing about salbutamol is you can adjust the dose. So you can give 1 mic per kilogram per minute to 10 mic per kilogram per minute. So you can adjust in between. So that is the advantage. Whereas aminophylline, you can't adjust because it's a fairly long-acting medication. Even if you change the dose, it will take several hours to take effect. But salbutamol is something that you can change very frequently, the dose, based on the response. But in recent times, one of the most about salbutamol again, the common side effect of salbutamol is it can cause tachycardia. Because it's a sympathomimetic agent. Second thing is it can also increase the VQ mismatch, right? The IV magnesium sulfate, the advantage is the advantage is you can give it as a bolus, right? So this is becoming very popular, especially if you had gone to the PCU, you'll find that this is one of the commonest drugs being used for acute exacerbation of asthma. So it can be given as a bolus, very limited side effects. But if you are needing more than one bolus, you need to keep magnesium under check because magnesium overdose can cause cardiac arrhythmias, cardiac arrest. And if you are giving magnesium sulfate, as you know, you might remember in obstetrics, this is one form of treatment for preeclampsia. So it can quickly bring the blood pressure down. So you need to monitor the blood pressure as well as you need to monitor the ECG. And if you are giving more than one dose, you need to monitor the magnesium levels. Right. So you will need to know certain drug dose, definitely salbutamol dose you need to know. So if the child is less than 5 years, the dose will be 2.5 milligram. That is 0.5. So 1 ml, so salbutamol vial, 1 ml will have 5 milligrams. So if the child is less than 5, you give 0.5, that is equal to 2.5 milligram. If the child is more than 5, you give 1 ml, that is 5 milligram. Protropium, so generally protropium is initially given mixed with salbutamol in the 3 back-to-back nebulizations. So less than 2 years dose is 125 mics, that is 0.5. If they are more than 2 years, you can go to 250 mics, that is 1 ml. Prednisolone dose, usually we give a higher dose, 2 milligram per kg. Hydrocortisone dose, you need to know, 4 milligram per kg every 6 hourly. But you don't have to remember these doses. IV salbutamol, magnesium sulfate, aminophylline doses, you don't need to know. But still you need to know the principle, such as what to monitor, how to give, those sort of things you need to know. So this is the salbutamol vial. As I said, 1 ml has 5 milligram. Dose is if the child is less than 5 years, you give 0.5. If the child is more than 5 years, you give 1. If protropium, 1 ml has 250 mics. So if the child is less than 2 years, you give 0.5. If the child is more than 2 years, you give 1 ml. This is the magnesium sulfate vial. Right, now we move on to status epilepticus. Again, in a common scenario that you might encounter. So same principle. First, you need to stabilize the patient. So maintaining the airway is important. If you can keep the patient left lateral position, or if that's the best option, and you need to frequently suck out secretions. And if you think you can't keep the airway open, then you'll have to use certain airway adjuncts such as oral airway. You generally give oxygen, keep the saturation under monitoring. Then you better if you can put the IV cannula, right? Once you put the IV cannula, you will usually send blood for sugar because, as I said, hypoglycemia can worsen any condition. And if this is the first episode, you might do certain electrolytes such as sodium level, calcium, magnesium levels, right? Now, in terms of the management, when the patient is shaking, when the patient is having convulsions, it may not be very easy to get IV access. So if that is the case, you need to try different approaches. So you can give always per rectal diazepam. So diazepam comes in rectal solution. So you might, if you go to the PCU, they will have diazepam vials, right? There's a special rectal solution with a small probe where you can actually insert to the rectum and squeeze it, right? But if it is not available, you can use the same IV solution, take it to a syringe, put an NG tube through the anus and then inject it, right? Dose is usually 0.5 per kg. If that is not available, you can give midazolam. Midazolam can be given as IM. It can be given as, you can take it to a vial and inject it, not inject, you can put it into the oral mucosa or the buccal mucosa. And of course, there are preparations such as intranasal midazolam. So those are the two medications that are commonly used when there is no IV access. You will find in other guidelines, they will mention paraldehyde, which is again given per rectally, but paraldehyde is currently not in use. If you have IV access, then of course you can give intravenous action. There are certain medication that you can give. You can give IV diazepam, IV midazolam, or lorazepam. Those who have gone to the PB, the preliminary care unit, you will find sometimes they give IV levetiracetam, but you don't have to know about such high things. But at least if you know about IV diazepam and IV midazolam, that's more than enough. So once you give one agent, you wait about 10 minutes before you give a repeat dose. So if there is no IV access, you can give two diazepam doses or two midazolam doses. So maybe as the first line, you get give PR diazepam, and then in the meantime you get IV access. Then you can try the IV diazepam or IV midazolam, like that. You try twice before we move on to the second line medications, right? Second line medication, of course, there are two. One is IV phenytoin, the other one is IV phenobarbital. They have their own side effects. So phenytoin can cause cardiac arrhythmia, so ECG has to be monitored. Phenobarbital can cause respiratory depression. Now, especially if we had given something like diazepam twice, people usually prefer phenytoin because if you give phenobarbital, the patient will stop breathing and they will have to start ambient ventilation. So if the second line doesn't work, then of course you will have to intubate and ventilate with you generally induce with thiopentone or propofol. Now in real scenario, if we go for intubation and ventilation, as you know, we need to have a PICU, otherwise you can't intubate. So because of that, we try different approaches. Sometimes we actually give both second line agents. Sometimes we start off with IV phenytoin and then we give phenobarbital also, although it is not technically correct because of the lack of facilities we might do. And you will also find that most of the time, if the things don't settle, we start them on IV midazolam, right? Let's go through the doses. So rectal diazepam dose you will need to know, because wherever you are, even in the remotest area, they will have diazepam, either rectal solution or IV. So you need to know the dose, 0.5 per kg. Midazolam, buccal, same dose. You will need to know phenytoin and phenobarbital because it's very easy to remember. 20 milligram per kg. You need to generally dilute it and give it as a infusion over 20 minutes, right? All right. Generally, when we used to have face-to-face sessions, I would call up 2 or 3 students and try to demonstrate these things. But since we can't do because of the online situation, I will at least kind of take you through how it happens in the exam, right? Generally, the examiner that you go to will have the case scenario like this. So he will have these instructions, right? Now, for example, this is an anaphylactic case. So 8-year-old boy presented with cellulitis and somebody had started him on IV penicillin, but as soon as penicillin was given, he had difficulty in breathing, swelling of the face, urticaria. And so the examiner will say, okay, you need to assess this patient and tell us how you manage. So, first thing, if I were the student, I will probably say, okay, it sounds like anaphylaxis. So I will quickly get adrenaline. I will tell the dose is 8 weight is 24. So 0.3 milliliters of IM adrenaline, 1 in 1000. Using a 23 gauge needle, I will inject it to the anterolateral thigh. And I will keep on repeating it till the patient stabilizes every 5 minutes. Then, of course, maintain airway, breathing, circulation. So if he has stridor, I will be nebulizing with adrenaline, 1 in 1000, 5 vials. And if he's wheezing, I will start salbutamol nebulization. If he's in shock, I will give 0.9 saline, 20 ml per kg. Like that, I will go on saying, right? But the first and the most important thing is you recognize what the emergency situation is, otherwise you won't be able to manage it. So listen, so this piece of paper will not be given to the student, right? So you will not be able to read it. So because of that, you need to listen to the examiner very, very carefully, right? Otherwise, if you don't get what the emergency situation is, you won't be able to get marks. Right. So this is another common scenario that you come across in the emergency medicine viva. So that is croup. Classic history is you have a 9-month or 10-month-old child, previously well. In the morning, he had mild coryza symptoms and a little bit of fever. Then his cough was gradually worsening, and at the end of the day, it was like a barking cough. And in the morning, early in the morning, he's having difficulty in breathing, and he's making sounds like that is the stridor sound, right? And very easy to recognize. So then you will have to say this based on the history, this most probably looks like viral croup, right? Or acute laryngotracheal bronchitis. Of course, there can be other reasons which for stridor, such as for in-body ingestion or epiglottitis. Thankfully, we don't see it because of the wide availability of hip vaccination. When anaphylaxis, we learned they can have stridor. So what do we do? First thing is you don't disturb the child. Now, stridor means there is a partial airway obstruction. That is why the sound comes. If you try to manipulate the airway or if you try to disturb the patient, then the child might get excited and start crying. And actually that partial airway obstruction can quickly convert into a full airway obstruction and the patient will die. So the most important thing is you keep the child calm, quiet, without disturbing him too much. We generally don't even put the child on the bed. We just keep the child on the mother's lap as it is and get the mother to do certain things for us, right? And you never examine the throat, because if you examine the throat, you might actually, the child might get upset and you'll be having a major trouble. So we start oxygen and the mother can, mother can take the mask and keep it on the child rather than you doing it. Then the most important thing is steroids, right? So you don't even cannulate, right? So as a temporary measure, you can just like in our anaphylaxis scenario, you can start adrenaline nebulizations. You break 5 vials and nebulize it with oxygen. That gives a temporary relief, right? But that is not a permanent thing. Can cause rebound. So you need to give steroids. Steroids, there are 2 ways you can give. You can either give as nebulization. You can give nebulization. You can nebulize the patient with budesonide, so commonly known as Pulmicort by the trade name. Or if the patient can take orally, you give oral dexamethasone, right? This oral dexamethasone dose you need to remember 0.15 milligram per kg. Remember, dexamethasone tablet is 0.5, right? So suppose if the child is 10 kilogram, you need 0.15 per kg means 1.5 milligram. That means you need 3 tablets. So you need to know such practical knowledge as well, right? If you go through especially American textbooks, you will find the dose is 0.3 milligram per kg, almost double. But the problem is we don't use it because we don't have the double strength tablet. So we stick to 0.1 milligram per kg, right? Then we move on to SVT, supraventricular tachycardia, again a common scenario in pediatric practice, but we haven't given it regularly for the exam. Nevertheless, it's important to know because, we might give it for your exam, right? So how do they present? Usually, they may have a pre-existing cardiac condition, something like ASD or VSD, or the thing to note is the child may have, so one common trigger for SVT is pneumonia and SVT, so you might get a history like that. But the key important thing is there is extreme tachycardia. right? So in a neonate, so it might, or small child, it might be more than 200. So if it is more than 200, you can jolly well know or think that it could be a supraventricular tachycardia. So ECG, of course, will help you to differentiate. So you have, so the top ECG, you have tachycardia about 150, but you can clearly see the P waves. Whereas in the lower one, you can still have, I'm sure you can appreciate the tachycardia, but you can't see the P wave. So absent of P wave is the one that differentiates between sinus tachycardia, which is a very, very common thing in children, and supraventricular tachycardia, which is a pediatric emergency. All right, so you need to do the same thing as ABC. So even if you don't know the specific management, you should be able to tell about how to manage airway breathing circulation. Now, management of SVT depends on whether the patient is hemodynamically stable or not, and if the patient, whether the patient is conscious or not, right? Now, when you are putting a cannula, so you need IV medications in this scenario. So it has to be closer to the heart. So usually we try to get a large vein, either a neck vein or a cubital fossa vein, so that when you inject drugs to that, it will quickly go to the heart. Because the commonest drug that we use is adenosine. Adenosine has a very, very short half-life, maybe several minutes. So if you insert it inject it to a peripheral line, such as, on the hand or the foot, by the time it reaches the heart, it's already disintegrated, right? It may not be very useful. So if the patient is stable, that is, patient, although has tachycardia, like, tachycardia may be, the heart rate may be as high as 200 or 250, but the patient still is capable of maintaining his blood pressure. So when you record the blood pressure, you can get a blood pressure reading and the patient is not in shock. So if that is the case, you can try vagal maneuver. So vagal maneuvers is you do certain procedures to increase the vagal output. Now, in small babies or small children, you can get some ice into a plastic bag. You can keep it over the face of the child. So when there is cold on the face, the vagal nerve starts reacting. Then all the children, you can try Valsalva maneuver, right? So where you ask the child to close the glottis and expire against the closed glottis. That will also activate the vagal system, which will come down the heart, bring down the heart rate. Now, in all the textbooks, you will find there are certain things such as eyeball pressure, where when you press on the eyeballs, the vagal nerve stimulates. But we don't do it now because when you do that, sometimes, especially during the emergency, you might actually cause damage to the eyes. So there are cases of eyeball rupture, right? Don't do that. So try put the ice pack. Keeping an ice pack on the face is probably the preferred method. If the patient is not responding, then of course you need to give adenosine. All right. If the patient is unstable, that is, the patient having some circulatory collapse, he's in shock, blood pressure unrecordable, or you have given adenosine to the cubital fossa and the heart rate doesn't come down, then you need to do synchronized DC conversion, right? So one important thing about adenosine is that so you need to whenever you are giving adenosine, it has to be inserted to a large vein in the cubital fossa, and there should be a three-way tap, right? And you need two people. One is to inject the adenosine, and the other one is to give the saline push. So one will give the adenosine. As soon as it is given, the other person pushes it down and push it to take it to the heart. We are doing this because adenosine has a very limited half-life, right? So another emergency that you might get time to time is hypersonic spell. So this is a classic history would be diagnosed child with tetralogy of Fallot, right? And usually this is commonly seen in pink top, where the cyanosis is not that apparent, and the saturation are usually over 90. So these sort of children are not used to cyanosis and hypoxia. So all of a sudden, the infundibular area of the right ventricle goes into a spasm, and when that happens, the blood flow to the lungs will get diminished, And when that happens, of course, the child who's already desaturated will go into a hypercyanosis, hyperhydrotic spell. So because the hypoxia is quite dangerous, as well as these children, they get scared, which will aggravate the whole situation. So what we need to do is, we need to somehow or other get more blood across the infundibulum to the lungs. So there are several mechanisms. One thing is, you can reduce the spasm of the infundibulum, or else you can increase the pressure in the right ventricle, either by giving IV fluids or doing certain maneuvers to push blood into the right ventricle, so that the pressure in the right ventricle goes up, and that will be able to overcome the pressure, the pressure created by the spasm of the infundibulum, right? So let's see how it is managed. So we'll usually follow the ABC approach, give high flow oxygen. And as I said, the first thing that you can do is, we can increase the venous return to the right ventricle, so that the right ventricle pressure goes up. So we put the child in knee chest position. When you put the child in knee chest position, I will show a diagram in the next slide. All the blood in the lower limbs quickly pushed onto the right heart, which can overcome the pressure at the infundibulum. If that doesn't work, you give put an IV line and you give boluses. Usually we need several boluses to achieve the required effect. So we give 20 ml per kg 0.9 saline as soon as possible, and we might have to give 2-3 boluses. Now, when the cyanosis is there for some time, the child goes into acidosis. So because you go, the tissue, especially muscles and skin, go into anaerobic metabolism, lots of lactate is produced, and you go into acidosis. When the acidosis is there, things actually get worse. So you can give IV bicarbonate. And we talked about how to reduce the spasms of the infundibulum. So the best medication for that is IV propranolol. Then I told you that when this hypoxemia occurs, children get scared, they are very upset, and it actually can aggravate the whole situation. So because of that, to calm the child down, you can give subcut IV morphine. Right? All right. Okay, so this is how you put the child on knee chest position. Choking child, another emergency that you might frequently encounter, but we haven't given a choking child for the emergency scenario for a very, very long time. So because of that, it's important for you to know the basic principle. Choking means child is eating on something or keep something inside the mouth, maybe a piece of toy, and all of a sudden it goes into the throat and gets lodged in the throat, obstructing the trachea. So this is a fairly dangerous thing. The management depends on if the child, whether the child is alert and able to cough, or if the child is drowsy and unable to cough and child not breathing. So if the child is alert and coughing, then of course you don't need to do anything. You might actually encourage coughing and stay with the patient, call the ENT surgeon and anesthetist as quickly as possible, and put a bronchoscope and take it out. But it's a different thing if the child is alert but not able to cough, right? So if the child hasn't lost consciousness, if the child is kind of drowsy, although the child is conscious, unable to cough, then of course you need to do this procedure called back blows and chest thrust, right? I'll show you in the next slide. Older child also, you can do a similar thing. So if the patient is unconscious, then of course you start the CPR method, that is chest compressions and ventilation. And of course, as I said, ENT surgeon and anesthetist are two important key people who should be immediately called. So this is how you give the chest thrust and back blows and chest thrust, right? So, so you keep the child on your knee and keep the mouth open, and between the two scapular blades, using the palm of your hand, you hit hard, right? So you hit hard 5 times, right? So you hit on the back with the palm of your hand 5 times, and that pressure and the vibration can dislodge the foreign body. And so at the end of the 5 blows, you inspect inside the mouth and see if the foreign body has come into the oral cavity. If that doesn't work, you turn the patient over like this, and with your 2 fingers, you push on the sternum inwards and backwards and try to generate a pressure to push the foreign body out. This also you do 5 times, and then at the end you inspect the mouth and see if that foreign body has come out. So you can repeat the procedure several times till the foreign body comes out or till the ENT surgeon is there to help you. You can do the same thing in an older child like this, do the back blows and chest thrust. You may have heard or at least learned in the early stages of at school something called Heimlich's maneuver, where you get behind the patient and push on the upper abdomen. So it is no longer recommended in standard textbooks, especially Royal College as well as Australian emergency guidelines, simply because the pressure generated by the Heimlich's maneuver is not enough to dislodge a foreign body. That's number one. Number two is that they have found that when you do the procedure, there is a risk of trauma to the spleen and the liver. So rather than Heimlich maneuver, now all the emergency guidelines will mention about back blows and chest thrust. Right. So I will give you another example of a practical scenario, right? Okay. This is a scenario of a ventricular tachycardia, 2-year-old boy. He was crying excessively and heart rate is 240. So that's the most important thing. So you need to do the airway breathing circulation, get an ECG and the rest of the monitoring in situ and do the management as I told you earlier. Right, dengue shock, hopefully you have had lectures as part of your CLDs. You may have had a section on dengue and you had a section, I think you had one IWC on dengue shock syndrome, right? Pretty easy to remember if you can remember this chart, right? So, shock, as you know, dengue hemorrhagic fever, there are 4 grades. Grade 1 is positive tourniquet, grade 2 is spontaneous hemorrhage, grade 3 and flu are part of dengue shock. Grade 3 is compensated shock, so the patient may be having tachycardia, capillary fill time may be prolonged, but the blood pressure is still recordable. However, the difference between systole and diastole, which we call pulse pressure, is 20 or less. That is compensated shock. Dengue shock syndrome or uncompensated shock or grade 4 shock, DHF grade 4 is where the patient may be tachycardic, capillary fill time prolonged, pulse may be not, you may not be able to palpate the pulse, and the blood pressure is unrecordable, right? So most of the time, your scenario will be a case where the patient comes with profound shock or grade 4 shock, right? Now let's have a look at the 2 arms. So the arm, this left arm is compensated shock, where the patient is tachycardic, capillary fill time may be prolonged. However, the blood pressure is still recordable, but the blood pressure is, the pulse pressure is narrow. So then you, so just like, you know, you need to repeat the airway breathing circulation. So you maintain the airway, start high flow oxygen, get 2 wide bore cannulas in. Then the treatment is 10 ml per kg of 0.9 saline over 1 hour, right? Then you reduce the rate according to the risk, the parameters. But we will focus more on the left hand side, that is profound shock, where you have tachycardia, capillary fill time is prolonged, and the blood pressure is unrecordable. So if that is the case, you again do the airway breathing circulation part, put large bore cannulas. Then the most important thing, or the first thing, is you give 0.9 saline 20 ml per kg as fast as possible. As fast as possible till the blood pressure is picked up or blood pressure is recordable and you can feel the pulse. So you may not need to give entire 20 ml per kg. Sometimes when you are like somewhere like 15 ml per kg, you might get the pulse and the blood pressure may be recordable. If that is the case, you stop and then move downwards. Suppose you respond to the initial fluid bolus, then of course we give another bolus of 0.9 saline, 10 ml per kg over 1 hour. So after that, you can just like this on the left side arm, you can reduce the fluid rate. And the few things that you monitor are, you need to monitor pulse rate, respiratory rate, then urine output, saturation, right? And of course, PCV. So you generally have to monitor them every 15 minutes. If the patient doesn't respond, then of course, hopefully by the time you put the cannula, you have sent the blood for full blood count, liver enzymes, blood group indeed, those sort of things. But if group indeed has not been sent, you send it at this point before you start our colloid, that is dextran 40, right? So that is the preferred colloid nowadays, although we have a bit of a shortage of dextran, so dextran 40. It is also given as 10 ml per kg per over 1 hour. So, other than the initial bolus of 20 ml per kg as fast as possible, all the other boluses are generally 10 ml per kg or 1 hour. There are of course occasions where we give 5 ml per kg bolus, especially when the patient is heading towards fluid overload. So once dextran is given, if there's response, of course, you again convert to 0.9 saline and you can adjust the dose. You can come down on the fluid rate according to the patient's vital parameters. If no response, then you need to decide based on the hematocrit. If the hematocrit is very low, that means patient is bleeding inside. Then, of course, you need blood. If grouping and cross-matching had been done, you can give group and cross-match blood. Blood is given at a rate of 5 ml per kg per hour. But if there is no response and if the hematocrit is still high, that means patient is still leaking very fast. Then you give another bolus of colloid. Is this chart clear? I know it's maybe a little bit confusing, but hopefully you have seen enough dengue patients in this appointment, as well as you may have learned quite a lot from the IWC. Even very recently, we had a patient who had presented with shock. I think it was one of my on-call nights. A big boy who came with shock, and we had to give several dextran boluses also during, I think that was on the PhD on 18. There was one patient, right? Hopefully you had seen the monitoring chart in that child. Right. Again, I'm saying this again. Please, if you have any queries and if you are too scared to ask, just type in the chat box. Right. Septic shock, again, another type of shock, a fairly common thing, right? Same principles, but the most important thing is in septic shock, antibiotics are very, very important. There's something called golden hour in septic shock. I wonder whether I'm sure there were a few students. Can you remember there was a neonate who came, a small baby transferred from from another teaching hospital, where the mother had complained of fever, but the staff had not paid much attention and had not started IV antibiotics. So if you do not give antibiotics, IV antibiotics within the first hour of onset of sepsis, it actually starts an irreversible process, and we may not be able to save the child despite our best management, right? So it's very important that you get the IV antibiotics as soon as possible. But just like any emergency, you start off with airway breathing circulation. They need high flow oxygen, and important things are these. So you have to put 2 large bore cannula or at least intraosseous access. If the patient, since the patient is in shock, so you need to first stabilize him, give 0.9 saline, 20 ml per kg, very, very fast, over 5 to 10 minutes. You can repeat the boluses. You might have to give 2-3 boluses to get the circulation up, because in septic shock you go into a vasodilation, right? So you need to give a lot of fluids. Then you need to keep monitoring the blood pressure. So take blood culture and start antibiotics. So preferred antibiotics would be IV ceftriaxone or cefotaxime. So when you are giving the second bolus, it is time to start ionotropes. So there are 3 ionotropes that you can use: dopamine, adrenaline, or noradrenaline. You don't need to know any of the doses, but at least know that you need to start ionotropes once you need the second bolus. Usually you keep the urine output a little bit high, 1 ml per kg per hour. Remember, ionotropes can be given both through the intravenous line or even through the intraosseous line, right? Most of the time, especially in refractory shock, they may have a relative cortisol deficiency. So when that happens, because of that, you give a small dose of hydrocortisone, like 50 milligram, 6 hourly. I think now we are here for the final final emergency scenario, diarrhea and dehydration. Hopefully, you have had at least somebody talking to you about management of dehydration, so you know the basic principles. Hopefully, but so the history is there might be a small child, maybe 1 or 2 years, had a watery diarrhea, and now hadn't been drinking fluids, and over the next few hours, like the last few hours, he hasn't been passing urine and he's becoming progressively drowsy. So then the examiner will ask you how to manage this patient. So you need to first know that there are three categories of dehydration: no dehydration, some dehydration, and severe dehydration. Remember, this is the WHO categorization. If you read especially other textbooks such as Nelson or even Australian ones, you will find they use a different category called mild, moderate, severe. But for you guys, please stick to the WHO category, because that is the same category thing that will be asked at the exams, not only the acute viva, but also in the theory exam. So no dehydration, some dehydration, severe dehydration. This corresponds to the loss of fluid, the amount of fluid loss. So no dehydration means the fluid loss is less than 5% of total body weight. Some dehydration means the fluid loss is 5 to 10% of the weight, and severe dehydration is more than 10% of the weight. Now, diarrhea management is, whether it's emergency management or routine management, will mostly be fluid management, where you need to cover three components. First, you need to correct the deficit. So if there is dehydration, you need to give that fluid back into the body. Then, of course, just like any other illness, you need to give maintenance fluid. And another thing is the diarrhea is going to continue. We will never give medicines to stop diarrhea. So whenever there's diarrhea, there will be ongoing losses. So whenever there's a loss in the diarrheal fluid, you need to replace that. So these three components are there in the fluid management. Now, the first thing is you need to know the features of dehydration, where you will need to demonstrate at the exam. So you do a top to bottom examination. So I will mention few. So sunken fontanelle, sunken eyes. When the child is crying, there are no tears appearing. The child might be drowsy. The oral mucosa will be dry. The child may be tachycardic, tachypneic, refill time may be prolonged, blood pressure may be low. When you pinch on the skin turgor may be reduced, and the urine output may reduce, peripheries may be cold. But the most important thing to decide on the degree of dehydration is the weight loss. So if you know the recent weight when the child was well, and if you now have the current weight after the diarrheal episode, then you can easily calculate the percentage loss and decide on which level of dehydration the child is in. So this is just the prolonged this reduced skin turgor, right? So if you go through this the classification, no dehydration means there's no features to suggest dehydration. The trick is to differentiate between some dehydration and severe dehydration. So severe dehydration is the medical emergency, whereas some dehydration is not a medical emergency. But if you don't manage the some dehydration properly, it will progress into a severe dehydration, and then it's going to be the emergency, right? So how I personally use is, so I generally, if the child is alert and if the child is thirsty and always looking for water, and when water is offered drinking quickly, that is suggestive of some dehydration. When you move on to, or you rather progress into severe dehydration, you become lethargic, you become drowsy, and even if fluid is given, the child will not take it. So that is a dangerous thing, right? Or sometimes they might be even unconscious. So let's this slide a bit complicated, but nicely summarizes each step. So let's first look at the green one, that is no dehydration. So I said there are three components of fluid management. One is correction of deficit, maintenance, and providing ongoing losses. So because there's no dehydration, you don't need to correct dehydration, or there's no deficit to correct. So you only have two components, that is maintenance and correct replacing ongoing losses. So you continue normal feeds, but you give extra fluid. So maintenance fluid here is usually given by home-based fluids, right? What are home-based fluids? You can give king coconut water, rice kanji, soup, orange juice, lime juice, like that, right? But whenever you have diarrhea, you replace it with Jeevani or oral rehydration solution. I will tell you what the dose is. Of course, any diarrhea, you may already know, we give zinc supplementation as well as probiotics. If there's some dehydration, I said the patient has lost 5 to 10% of the weight. There is a formula where you can convert the percentage to an actual volume of fluid. Now, 1% is equal to 10 milliliters of per kg. So now that is why you might remember in dengue fluid management, we say 5% dehydration correction. That is 5 into 10 is 50 ml per kg. So we have in some dehydration, we have lost about 5 to 10%. So we take the average 7.5. So when we convert it to the volume, I said 1% equals 10 ml per kg. So 7.5 equals to 75 milliliters per kg. So that is the amount of deficit in this child. So we need to give that amount. And so please focus on the yellow column, right? So we replace it with oral rehydration solution, 75 ml per kg, and that has to be given over 4 hours. So once that 4 hours are over, then you reassess the patient and decide where the patient is. And once the patient is no longer dehydrated, the management is going to be like the green zone, no dehydration. Now I want you to focus on the red zone, red column, which is the thing that you will frequently get at the exam. So severe dehydration means the patient has lost more than 10%. So 10% into an actual volume is 10 into 10 is 100 milliliters per kg. Now 100 ml per kg is a fairly huge volume. Now if the child is 10 kilos, you need to give 1 liter, a big amount, right? So we don't give it at once. So we generally give a proportion. So like 30 ml per kg quickly, and the balance 70 ml per kg, we give it over a long period. Now, suppose the child is less than 1 year. So we give the first 30 ml per kg over 1 hour, and the balance of 70 ml per kg we give over 5 hours. If the child is more than 1 year, we can do this a bit quickly. So first 30 ml per kg you give over half an hour, balance you give it over 2.5 hours. So if the child is less than 1 year, you correct the hydration, correct the dehydration, severe dehydration over 6 hours. If the child is more than 1 year, you correct the severe dehydration over 3 hours. So what is the fluid that you can use? Usually we use 0.9 saline, but you can use other things like Ringer's lactate or Hartmann solution. This is an emergency, so just like in dengue or any other emergency, you need to monitor the child frequently. So every 15 minutes, you need to check the vital parameters. Once, of course, the dehydration is corrected, that child will go to the green zone, that is no dehydration, and then you continue with the maintenance and replace ongoing losses. Well, unfortunately, I don't have a slide about the volume, so you will need to write down, right? I'm talking about replacing ongoing losses. And the fluid is oral rehydration solution. The easiest formula to remember is the nice formula, that is 10 ml per kg. So if the child is 10 kilos, with each diarrheal episode, you give 10 ml per kg, that is 100 ml of Jeevani whenever the child passes stools. But WHO gives a different formula. So between 0 to 2, you give like 50 to 100. Between 2 to 5, you give about 100 to 200. Then after 5 to 9, you give about 200. But more than that, more than 9 years, you give as much as the child drinks. But the easy way to remember is the nice guideline one, that is 10 ml per kg of Jeevani whenever the child passes stools. So this is another practical scenario. So where they will describe how the child comes, the diarrhea, not past stools, not past urine, and the child is drowsy, something like that. And you need to first assess the dehydration. So you need to go through the clinical features of dehydration, pretend that you are actually with the child, and tell the examiner how you are assessing. Then the examiner will give you the responses, and then you will invariably be able to diagnose severe dehydration. Then, of course, you do the management according to how I said. So that brings us to the end of the lecture. Now it's time for questions. So if you have any questions, please ask now, or you can type them in the chat box, or else you can ask from one of the registrars once you go to the ward, or you can ask me personally. So the things that you need to do are, number one, you need to get a list of medication that you need to see. Go to the emergency trolley and have a look at these medicine vials, right? And have a look at the cannula sizes, the color codes, not only the cannula, the needles. And make sure at least you see an intraosseous gun and the intraosseous the needle. If you can't go to the PCU, at least Google from the internet and have a look at it. All right. Do you have any questions, Chamat? Hello? Sure, right? Okay, I hope you learned something from me. At least, if, I know it's quite late into the night, but at least if you had written down something, and I will definitely share the presentation, but at least go through it leisurely, make some short notes, clarify any queries from the registrar or even the house officer. We have very good house officers. All our house officers are very up to date about this emergency management. Just ask them. And please remember the steps, right? It's very easy. Probably the easiest exam that you will ever come across in your medical career. It's the same scenarios that we are giving. So I honestly can't understand why a student would get less than 70 marks in this assessment. Right? Okay. Thank you for joining. And I'm really sorry about, rescheduling this lecture to a very rather uncomfortable time of the day. All right. If you have no questions, let's say good night, right? All right, Chamath. Right. Thanks.
Thank you, sir.
Thank you.
Thank you, sir.
Bye.